are going to start this session. In any piece of this session where you lose my voice or you lose the presentation, please let me know because this is a virtual presentation, so it might happen that the internet connections become a little bit weak at some point of time and you might lose me. So let me know whenever you lose me. In this session, the first half of this session or majority of this session, we are going to talk about cranial nerve nuclei and what happens if certain piece of the cranial nerve nuclei or the cranial nerves themselves get damaged. That is what is the major essence of these 2 hours. In the later half, we are going to discuss few lesions of the brainstem, but the concentration of majority of this session would be on cranial nerve nuclei and cranial nerves, the area of supply, the nuclei of the different cranial nerves, and what happens when cranial nerve damage happens. So let me start with general somatic sensations from the head and neck. And general somatic sensations from the head and neck, we are talking about pain, temperature, touch, two-touch discrimination, vibration. As you know, in any of these sensory pathways, you have three orders of neurons. The first order neurons, the cell body of the first order neurons, usually lie outside the central nervous system. Like in the spinal cord, we have the dorsal root ganglia, which has the pseudo-unipolar neurons, and they were lying outside the central nervous system. So similar to that, in the head and neck region, the pain and temperature and the general sensations from the head and neck region usually go to a ganglion, which is lying outside the central nervous system. And this general sensations from the head and neck region mostly go to one of the ganglions of the trigeminal nerve. And this ganglion is called the trigeminal ganglion. It is present, it is also sometimes called Gisserian ganglion. So if you hear the word Gisserian ganglion or trigeminal ganglion, these are the same. It is present in the middle cranial fossa, this ganglion, which is outside the central nervous system. It has peripheral processes, and these peripheral processes are going to form the three divisions of the trigeminal nerve: the ophthalmic, which is going to supply the forehead, the maxillary, which supplies the area over the cheek, and then mandibular, which supplies the area over the chin. So these are the three divisions which are going to be formed by the peripheral part or the peripheral process of the Gisserian ganglion or trigeminal ganglion. Besides the trigeminal ganglion, there are also ganglions of the seventh nerve, which is the geniculate ganglion. It takes supply from a small part of the head and neck. And similarly, ninth and 10th cranial nerves have ganglion, which is called the superior ganglion. These are the ganglions in the head and neck, which take the sensory sensations from the head and neck region and then transmit them to the three nuclei which you have in the brainstem. The first one we have already talked about is the spinal trigeminal nucleus, which receives the pain and temperature sensation. Then you have the principal sensory nucleus, which receives the two-touch discrimination and vibration sensation. And the third one, which is present in the midbrain, receives it's called the mesencephalic nucleus and receives the proprioceptive impulses from the muscles of mastication. Now, after relaying, these are the first order neurons. So these which are present in the Gisserian ganglion or the geniculate or the superior ganglion, the central fibers of these neurons are going to relay based on the type of sensation into these three nuclei, into spinal trigeminal nucleus, principal sensory nucleus or mesencephalic nucleus. So these are the cell bodies of the second order neurons for the general somatic sensations from the head and neck region. From there, the second order neurons, part of them would cross the midline and part of them will remain on the ipsilateral side. So there would be the fibers which will cross the midline, they will form the dorsal trigemnothalamic tract, and the ones which are going to remain on the same side will form the medial trigemnothalamic tract. They are going to go to the nucleus in the thalamus, which is called ventro-posterior medial nucleus. So if you remember in the spinothalamic pathway, they were going to, and the dorsal column pathway, they were going to go to ventro-posterior lateral nucleus of the thalamus. These fibers from the trigemnothalamic tract, they are going to go to the ventro-posterior medial nucleus of the thalamus. And from there, the third order neurons will arise, which will go to the post-central gyrus. So this is the pathway of general sensations or somatic general sensations from the head and neck region all the way to the head to the post-central gyrus. Then we come to the general visceral sensations and also special visceral sensations, which are the general sensations from the tongue as well as the special sensations, which are the taste sensations from the tongue. And similarly, you would have a ganglion outside, and this ganglion also mainly is the trigeminal ganglion, where these sensations, general sensations from the tongue are going to go. Then you have the seventh nerve ganglion, which is responsible for the taste from the anterior two-third of the tongue. So that is the geniculate ganglion. And posterior one-third of the tongue and the root of the tongue are supplied by the ninth and the 10th cranial nerve. So the first order neurons are going to synapse with the nucleus in the brainstem, which is present at the level of medulla, which is called the nucleus solitarius. And the upper part of this nucleus, we have already talked about it, is responsible for taste sensations. The second order neurons will cross the midline and they will reach the ventroposterior medial nucleus of the thalamus. Then we are coming to the motor control. Most of the motor nuclei in the brainstem, if you see, we know that there is a third nerve nucleus, fourth, sixth, and the 12th nerve nucleus, which are going to supply third, fourth, sixth supplies the muscles of the eye, and the 12th nerve nucleus supply the muscle of the tongue. These nuclei, they receive bilateral supply from both the cortices. So you are basically, so you would not find, if there is a damage to one side of the brain, you would not find an upper motor neuron lesion for these nuclei because they are bilaterally supplied. Unless you have both sides affected, you would not find upper motor neuron lesion for the third, fourth, sixth, and 12th cranial nerve. The reason is that these nuclei are getting bilateral supply from both cortices to each of these nuclei. The only exception in this is the seventh cranial nerve nucleus, which is the facial nerve nucleus, which does not receive the lower part of it receives only contralateral supply. So we will talk about it in later part of our session when we are going to talk about the facial nucleus. But most of these motor nuclei of the third, fourth, and the sixth cranial nerve and the 12th cranial nerve, you can see that they are receiving bilateral supply. That means right and the left oculomotor, right and the left trochlear, right and the left abducens, right and the left hypoglossal. They are getting the supply from the right side as well as from the left side. So if you damage one side of the corticobulbar or corticonuclear fibers, still the other side is supplying the nucleus. So usually what you are going to get with the damage of these nuclei would be the lower motor neuron type of paralysis rather than upper motor neuron type of paralysis, because all of these nuclei which are supplying the muscles, which have originated from somites, is going to get bilateral supply from both motor cortices. Now we also have some parasympathetic supply, and we have four parasympathetic ganglion in the head and neck region. One is in the eye, which is called in the orbit, which is called the ciliary ganglion, which supply the smooth muscles of the eye, the ciliary muscle as well as the sphincter pupillae. One is present in the pterygopalatine fossa, which is called the pterygopalatine ganglion, and this supplies the lacrimal gland and the submandibular gland. And then we have the otic ganglion just in front of the ear, which is going to supply the parotid gland. And then we have the submandibular ganglion, which is supplying the submandibular and the sublingual glands. So you are seeing these nuclei. So what you would find in parasympathetic nervous system is that you have a nucleus, parasympathetic nucleus of the cranial nerve. Like in this case, we are seeing the cranial nerve 3 has a parasympathetic nucleus, which is called Edinger-Westphal nucleus, and it is present at the level of the superior colliculus. From here, we have the preganglionic fibers, which are going to go to the ganglion, and this ganglion, the ciliary ganglion, is present inside the orbit. So the third nerve is going to carry the parasympathetic fibers all the way down into the orbit where your ciliary ganglion is. And then from the ciliary ganglion, there would be postganglionic fibers, which are going to pass through the short ciliary nerves, and they are going to supply the smooth muscles in the eye, which will constrict the pupil. So there is pupillary constriction, and there is also the ciliary muscles, which will make the lens more convex, so it helps in accommodation. So these short ciliary nerves are going to supply two muscles inside the eye. One is the sphincter pupillae, which constricts the pupil. The other is the ciliary muscle, which makes the lens more convex and helps in accommodation. The other parasympathetic nucleus which you see is the nucleus of the seventh cranial nerve, and it is called the superior salivatory nucleus. It is present at the level of the lower pons. From here, the preganglionic fibers will pass into branches of the facial nerve. The greater petrosal nerve is one of the branch of the facial nerve. The other is the chorda tympani, which is also the branch of the facial nerve. These fibers are going to pass through the branches of the facial nerve to reach the ganglion. And there are two ganglions. One is the pterygopalatine ganglion, which is lying just behind the orbit, and the other one is the submandibular ganglion, which is lying in the submandibular region. From here, the pterygopalatine ganglion is going to supply the lacrimal gland, and it is important in the formation of tears. So the tear production is through the pterygopalatine ganglion. Pterygopalatine ganglion also supplies in the nose, so it is also supplying the glands within the nose, as well as the lacrimal gland, which is important in lacrimation. Then you have the submandibular ganglion, which is going to supply the submandibular and the sublingual gland, which are some of the salivary glands. So if you have damage to the facial nerve nucleus or the branches which are carrying the parasympathetic supply to these ganglion, it can lead to dry eye as well as decreased salivation, because the facial nerve has a parasympathetic nucleus, which is important in salivation as well as lacrimation. Then we have parasympathetic nucleus of the ninth cranial nerve, and that is called the inferior salivatory nucleus. This is present at the level of medulla, and the branch, which is the tympanic nerve, is going to take the parasympathetic sensations, and over the eardrum inside the ear, there would be a plexus formed, which is called the tympanic plexus. From here, the lesser petrosal nerve will arise, which will take the preganglionic fibers to the otic ganglion, which lies just in front of the temporomandibular joint. And this otic ganglion is going to supply the parotid gland. So you have preganglionic fibers passing through the lesser petrosal nerve to the otic ganglion. Lesser petrosal nerve is a branch of the glossopharyngeal, and this is the nucleus of the glossopharyngeal. So this is the preganglionic piece, then the otic ganglion, and then the parotid gland. So what you need to understand is that there is an inferior salivatory nucleus of the glossopharyngeal present at the level of medulla, which supplies the preganglionic fibers through the lesser petrosal nerve to the otic ganglion, and the otic ganglion is the one which supplies the parotid gland, and it is one of the primary salivary gland, and it is important in salivation. This diagram is just showing you some of the special sensory cranial nerves. One is the olfactory, which is bringing the olfactory sense. And the receptors for the olfaction are present in the roof of the nasal cavity. So there is a cupriform plate. From here, the olfactory nerves pass directly to the brain, and on the undersurface of the cerebrum, you can see the olfactory bulb and the olfactory tract. So the sense of sensation, sensation for smell is passing directly from the roof of the nasal cavity to the brain, where you have the olfactory bulbs. If you have damage to the olfactory nerves, then you lose the sense of smell, and the condition is called anosmia. Then the second cranial nerve, we know that it is the optic. It is carried by the optic nerve, and you can see this is the optic nerves coming together, forming the optic chiasma, and then the optic tracts are going behind. If you have damage to the one optic nerve, you will lose, for example, the right side, you would lose the right visual field. If you have damage to the left optic nerve, you would lose the left visual field. Then the other sensory, special sensory nerves are the seventh and the eighth. Eighth, which has vestibular and cochlear component. Vestibular is responsible for the balance, and cochlear component is responsible for the for hearing. So if you have damage to the eighth, you may have loss of vestibulo-ocular reflex, which is when you move your head, the eyes move accordingly. So if you lose this reflex, there is a chance that you have damage to the eighth cranial nerve, or you lose balance also. This is also a sign for damage to the vestibular component of the vestibulocochlear nerve. And if you damage the cochlear component of the vestibulocochlear, then there would be deafness, because it is responsible for hearing. Now we are going to discuss each specific cranial nerve starting from 3rd to 12th. We are going to discuss their role and what happens if they get damaged. So if you see the 3rd cranial nerve, we are not going to talk the 1st and 2nd, because 1st and 2nd do not supply the brainstem, or they do not originate from the brainstem. The one which is originating from the brainstem is the oculomotor nerve. We know that oculomotor nerve is a motor nerve, and it has a parasympathetic component. So it's a mixed nerve. It arises at the upper level of the midbrain, and it supplies most of the extraocular muscles except two muscles. One is the lateral rectus, the other is the superior oblique. It has a parasympathetic component, which is important for pupillary constriction, and it is also in supplying the ciliary muscles. And these ciliary muscles are important for making the lens more convex and in accommodation reflex. Motor component of the oculomotor nerves innervates all extraocular muscles except the LR6 and SO4. LR6, that means lateral rectus, is supplied by the 6th nerve, and the superior oblique supplied by the 4th nerve. So the damage or disease to the third nerve will result in ptosis. So there would be drooping of the eyelid because levator palpebral superioris is important for elevating the eyelid. So if you have damage to the third cranial nerve, there would be ptosis. That means complete drooping of the eye. So it would not be partial ptosis, it would be a complete ptosis here. There would be pupillary dilatation because the constrictor pupillae is supplied by the third nerve, by the parasympathetic component of the third nerve. So the sympathetic overactivity will make the pupil dilated, and there would be lateral strabismus. That means the eye would be moved outward, and there would be ophthalmoplegia. You would not be able to move the eye because all the muscles of the eye are going to be paralyzed. So the eye would be outward and downward, and there would be ptosis, and there would be pupillary dilatation, which you see with the oculomotor nerve damage. You can see the third nerve coming out here from the interpeduncular fossa. So this is the interpeduncular fossa. From the medial side of the interpeduncular fossa, you can see the oculomotor nerve coming out. If you see this diagram, this is a little bit more complex diagram, but you can still see that there is a principal oculomotor nucleus which is made in red, and it is supplying all the muscles of extraocular muscles. So this is levator palpebral superioris, which is going to the lid. This is the superior rectus, and then you can see the inferior division of the oculomotor supplying the medial rectus, inferior oblique, and the inferior rectus muscle. The two muscles which it is not supplying is the lateral rectus and the superior oblique. The parasympathetic component, which is the Edinger Westphal, which is shown in blue, is going to go to the ciliary ganglion, and from the ciliary ganglion, you can see these dark blue fibers which are going to supply the constrictor pupillae and the ciliary muscles in the eye. Now we are coming to the fourth cranial nerve. It is the only nerve which comes from the back of the brainstem. So you can see it here, number 22 is the trochlear nerve coming out. It is the nerve which is going to supply only one muscle in the eye. We have one extraocular muscle, which is the superior oblique muscle. So in trochlear nucleus is present at the lower level of the midbrain, and it's a motor nerve, purely motor, not mixed. It's a motor nerve which supplies only one muscle in the eye, which is the superior oblique. So if you have a table looking at the nerves which are supplying the extraocular muscles, most of them are supplied by the oculomotor nerve. So medial, superior, inferior rectus, inferior oblique, these are the muscles which are supplied by the oculomotor nerve, and it is responsible for the movement of the eye. Ophthalmoplegia with eye turned down and out, this would be the position of the eye. So eye would be turned out and down if there is damage to the oculomotor motor nucleus of the oculomotor nerve. Eyelid elevation would also be affected because superior palpebral levator palpebral superioris is affected. So your eyelid cannot go up. So there would be complete ptosis. And then because of the parasympathetic nucleus, there would be pupillary constriction and loss of accommodation because you are not supplying the constrictor pupillae as well as the ciliary muscle. So there is mydriasis, which is the dilatation of the pupil, and loss of accommodation of the lens. So these are the findings for the oculomotor nerve. So this is given a little bit of more in a summary form. Trochlear nerve is important in eye movement. It is starting from the trochlear nucleus of the contralateral side. It supplies superior oblique muscle, and the damage to the trochlear nerve will result in diplopia, extortion of the eye. So when there is the extortion of the eye, you cannot depress the eye and adduct. So like you are going down the stairs, you need your eyes to go down and medially. You need your eyes to adduct and go down. So one you cannot completely adduct and move the eye downwards, This is the function of the superior oblique. When it is weak, you cannot adduct and move the eye downward. So when you are going down the stairs, one of your eye, which is normal, would be down, the other one would be a slightly up. So because the level of both eyes would be different, there would be diplopia or double vision, which you see in trochlea. So mostly patients with trochlear damage, when they adduct their eye and move the eye downwards, like looking down the stairs or reading something, they start to develop diplopia or double vision. Abducent, which is the sixth cranial nerve, is also important in the movement of eye. It supplies one muscle, which is the lateral rectus, and that if you have the damage to the abducent nerve nucleus or the abducent nerve, you would have medial deviation of the eye because oculomotor will pull the eye medially. So if you see the position of the eye, you would find out that the position of the eye in the third nerve palsy is downward and outward. While if you look at the position of the eye in the fourth cranial nerve palsy, you would find that the eye, when you are adducting the eye, it is not adducting completely here. You can see that it is not adducting completely and downward and medially. And in the sixth nerve, you see the eye moved inward because the damage of the abducent will allow the oculomotor nerve to pull the eye medially. So this is how the position of the eye would look in the sixth nerve palsy. This is the position of the eye which you see in the third nerve palsy. And in the fourth nerve, you cannot completely adduct and downwardly rotate the eye because of the spear oblique paralysis. Then we are coming to another important nerve, which is the trigeminal nerve. Trigeminal nerve is a mixed nerve. It has sensory component and it has a motor component. Although it is attached from the pons, there are three divisions of the trigeminal nerve, which are arising from the trigeminal ganglion, or the Gasserian ganglion, or the semilunar ganglion, which is present in the middle cranial fossa. And this ganglion is giving rise to the three nerves. One is the ophthalmic, which is sometimes called V1. So if you read V1, this means ophthalmic division of the trigeminal, which supplies the eye and the forehead. So eye and the forehead is sensory supply is by the V1, which is the ophthalmic. V2 is also purely sensory. It's called maxillary nerve. It supplies the cheek and the upper teeth. So all your upper teeth and the cheek area and the nose area is supplied by the maxillary division of trigeminal, which is also purely sensory. The mandibular nerve has a motor component attached to it. So it's V3. It is going to supply the skin over the mandible, the lower teeth, and it has a motor component which supply muscles of mastication. The fifth nerve also is important because it serves as a conduit for supplying the parasympathetic supply to the different ganglions. So if you see all the four parasympathetic ganglion, the ciliary, the aortic, the pterygopalatine, and the submandibular ganglion, they are all attached with the branches of the trigeminal nerve. Although they are parasympathetic ganglion and they are supplied by the branches from the third, seventh, ninth nerves, but the ganglion themselves are attached with the branches of the trigeminal. So there is a lot of skipping or movement of the nerves branches from the fibers are hitchhiking between the branches of the third, seventh, and ninth cranial nerve and the trigeminal nerve. So that detail we are going to do when we are going to do head and neck, because we are going to talk about the branches of those nerves and we are going to talk about the branches of the trigeminal and how this hitchhiking of the parasympathetic fibers is going through the trigeminal nerve. So what you need to know at this point of time, that trigeminal nerve is mainly a sensory nerve. It has a motor component which supplies the muscles of mastication, but it also acts as a conduit for the fibers of the parasympathetic nerves to reach the parasympathetic ganglions, which we have in the head and neck region. And there are four of them. One is in the orbit, which is the ciliary ganglion. One is behind the orbit, which is the pterygopalatine ganglion. One is in the temporal fossa, which is the aortic ganglion. And the fourth one is in the submandibular region, which is the submandibular ganglion. Now, this is the distribution of the three divisions of the trigeminal. You have the ophthalmic division supplying the forehead, the front of the nose, as well as the scalp up to the mid head or the lambdoid suture. So this is the area of supply of the V1 or the ophthalmic division of trigeminal. The lower eyelid, the cheek area, the upper lip, the upper teeth, and the side of the nose is supplied by the maxillary division of trigeminal, which is V2. And then the chin area and the area behind, in front of the ear and on the side of the scalp is supplied by the mandibular division of trigeminal, which is V3. Now here you are seeing the Gasserian ganglion. This is the Gasserian ganglion, and from the Gasserian ganglion you are seeing the three divisions. One is the V1, which is the ophthalmic division, and it is entering into the orbit. Then you have the maxillary division, which is passing through the foramen rotundum, and it will come out just behind the orbit. And then you have the mandibular division, which is arising from the Gasserian or the trigeminal ganglion and passing through the foramen ovale to reach the infratemporal fossa. So these are the three divisions of the trigeminal, and you can see they are all originating from the Gasserian ganglion, and then they are going to go to the pons, where they would arise from a smaller motor rootlet and a bigger sensory rootlet. And then the fibers are going to disperse into three set of fibers, one going to the medulla, where you have the spinal trigeminal nucleus, then the ones which are going to take the two-touch discrimination and vibration to principal sensory nucleus, and the fibers which are related to the mesencephalic nucleus will take the proprioceptive impulses. So here you are seeing the trigeminal nuclei, and you can see that the motor nucleus is here, and the sensory nucleus. There are three sensory nucleus. One is the spinal trigeminal nucleus, the other is the principal sensory nucleus, and the third one is the mesencephalic nucleus. Mesencephalic is for proprioception. The principal sensory or chief sensory nucleus is for touch, and the spinal trigeminal nucleus is responsible for pain and temperature. And then at the midbrain level, at the pons level, you also have a motor nucleus, which is supplying the muscles of mastication. Now you are seeing that there is a trigeminal ganglion which is present at the level of the middle cranial fossa, and it is giving rise to the three divisions of the trigeminal nerve. V1 going into the orbit, and one of the parasympathetic ganglion which is attached with it is the ciliary ganglion. V2 is also passing through the foramen rotundum to reach behind the orbit in the pterygopalatine fossa. So you can see the pterygopalatine ganglion attached to the maxillary nerve, the branches of the maxillary nerve. And then the mandibular division has its branches through which the aortic as well as the submandibular ganglion are attached. So as we said, that the branches of the trigeminal will act as a conduit for the parasympathetic fibers of the third, seventh, and the ninth cranial nerves. Now we are coming to the sixth cranial nerve, and we know that the sixth cranial nerve is the abducent. We have already talked about it. This sixth cranial nerve is going to supply only one muscle, which is the lateral rectus muscle. And if you have damage to the, sorry, before we finish up the fifth nerve, and then we go to the sixth nerve. So the fifth nerve, if you see there, these are the functions. Mastication, muscles of mastication are supplied by it. The motor nucleus of the trigeminal, these are the muscles of mastication. And if you have weakness or damage to the mandibular division of trigeminal, which supplies the muscles of mastication or the motor nucleus of trigeminal, the weakness of the ipsilateral jaw will result in deviation of the open jaw. So if you open the jaw, it would deviate to the side of the lesion. So this is what will happen in terms of the muscles of mastication. It also supplies the tensor tympani, which dampens the tympanic membrane, but damage to that is insignificant. Trigeminal ganglion supplies the face, anterior scalp, oral and nasal cavities, and orbit. And the major connection is through the principal and the spinal trigeminal nucleus. If you have damage to the principal sensory or the spinal trigeminal nucleus or the trigeminal nerves, there would be hemianesthesia, that means half side of the face would lose sensations of pain, temperature, touch, to-touch discrimination, vibration. Also, the anterior two-third of the tongue will lose general sensations. There would be corneal reflex would be lost because the cornea is also supplied by the sensory supply to the cornea is also coming from the trigeminal nerve. Proprioceptive reflexes go to the mesencephalic nucleus, which are coming from the muscles of mastication, and damage to this part is insignificant. Clinically, you would not find anything happening because of that. Abducent nerve, we know that it supplies one muscle, which is the lateral rectus muscle, and damage to this will result in the movement of the eye medially or inward. So you would have the medial strabismus if you have the damage to the lateral rectus muscle, which moves the eye laterally or outward. We are coming to the facial nerve, and this is one of the very important nerves. You should know everything about the facial nerve when we talk about facial nerve. So facial nerve is parasympathetic. It supplies the lacrimal gland. We have pterygopalatine ganglion, and it supplies the submandibular and sublingual gland via submandibular ganglion. Damage to or disease to the facial nerve, which is the lower motor neuron type of paralysis, results in Bell's palsy, hemifacial palsy, because all the muscles of facial expression are supplied by the facial nerve. So damage to the facial nerve or the facial nucleus at the level of pons will result in complete paralysis of half side of the face, which is called hemifacial palsy. But if there is a damage because of to the facial nerve itself, you call it Bell's palsy. Patient may lose partially the taste sensation because anterior two-thirds of the tongue, the taste sensation pass through the facial branch of the facial nerve, which is called the chorda tympani. There would be loss of salivation partially because of the damage to the fibers which are coming to the submandibular and sublingual glands, and lacrimation in one eye would also be reduced. May develop hyperacusis because there is one muscle in the ear which is called the stapedius muscle, which is important in terms of the hearing. And if that muscle is paralyzed because that is supplied by the facial nerve, you would hear loud sounds. So that is called hyperacusis. So these are the features of the facial nerve paralysis. We can see the facial nerve coming out at the junction of the pons and the medulla laterally, and it is entering into the internal acoustic meatus. So once it comes out, it goes directly through the internal acoustic meatus and enter into the ear. Within the ear, it gives a couple of branches, and then it comes out from the ear through this foramen, which is called the stylomastoid foramen. So you have the mastoid bone here. So between this and the styloid bone, there's a stylomastoid foramen just behind your ear. That's the place from where the facial nerve is going to come out from the skull. So first it goes into the internal acoustic meatus to enter into the ear, and then it passes through the ear through the stylomastoid foramen, comes out of the ear, and then it enters into the parotid gland. And once it enters into the parotid gland, which is lying just in front of your ear, it divides into its 5 branches, which are the temporal, zygomatic, buccal, marginal, mandibular, and cervical. These 5 branches are going to supply the face, the muscles of facial expression. So if you see here, this is the parotid gland, and you can see the facial nerve is making a plexus within the parotid gland and then dividing into its 5 terminal branches, which are the temporal, zygomatic, buccal, marginal, mandibular, and cervical. These 5 branches, if you don't remember their names, it's not necessary at this point of time. You would learn about the course of the facial nerve and the branches of the facial nerve here. The only reason why I'm telling you is that these branches are the ones which are going to supply the muscles of facial expression. So sensory supply to the face is coming from the trigeminal, while the motor supply to the face is coming from the facial nerve, which is supplying all the muscles of facial expression. Now, as we said, there is motor nucleus of the facial nerve, which is supplying the muscles of facial expression, which is shown in red. Then there are taste sensations from the anterior two-thirds of the tongue, which is going to the nucleus solitarius, which is shown in orange. And then you can see the superior salivatory nucleus, which is supplying the parasympathetic supply. So the parasympathetic supply is going to the pterygopalatine ganglion, to the lacrimal gland, and it is going to the submandibular ganglion, to the sublingual and the submandibular gland. So you have parasympathetic supply to the lacrimal, sublingual, and submandibular gland through pterygopalatine and submandibular ganglion. You have the sensory supply from the taste sensation from the anterior two-thirds of the tongue, and you have the motor supply to the muscles of facial expression and the stapedius muscle, which is inside the ear, which is being supplied by the facial nerve. Now, this is very important, and if you do not understand this, please let me know, because this is, this will help you to identify lesions. Is this an upper motor neuron lesion of the facial nerve or the lower motor neuron? We told you that most of the motor nuclei in the brainstem, they are bilaterally supplied, so they would not have an upper motor neuron lesion. Usually they would have a lower motor neuron lesion. But in case of the facial nerve, this is different. So this is an exception, and that's why it is very important to understand this. So there are 2 parts of the muscles in the head. One is the upper 1/3 of your facial muscles, which are the forehead muscle and your upper eyelid muscle. These are the upper 1/3, and then you have the lower 2/3 of your face. Now, the upper 1/3, and this is the lower 2/3 of your face. The facial nucleus, which you see, also has 2 parts. The upper part supplies the upper 1/3, and the lower part supplies the lower 2/3. So if you see here, there are 2 parts of the facial nucleus, motor nucleus, which is present at the level of pons. The upper part of this facial nucleus supplies the upper 1/3. The lower part of this facial nucleus supplies the lower 2/3. So it's like this. This upper part of the facial nucleus, which you see here, is supplied by the fibers from both the cortices, from right as well as the left cortex. So if you damage the upper motor neuron, the upper 1/3 will not be paralyzed because it is supplied bilaterally. If you damage here, these fibers are still intact. So the upper one third in terms of one third of the face will not get paralyzed if you have an upper motor neuron lesion. If you have a lesion above the pons level where the corticonuclear fibers are coming down for the facial nucleus, because the upper part of the facial nucleus which supplies the upper one third, it is bilaterally supplied, you would not have, if one side is damaged, the other side is supplying it, so you would not have paralysis of the forehead. So there would be sparing of the forehead in an upper motor facial nucleus paralysis. But if you have a lower motor nucleus paralysis, then either this nucleus or the facial nerve itself, complete half side of the face is going to get paralyzed. So this is the difference which you need to understand. So if you have the paralysis here, because the upper part of the facial nucleus is supplied bilaterally, this part would be spared. So you would only have the lower two-thirds of the contralateral side, which is going to be paralyzed in an upper motor neuron type of facial paralysis. In a lower motor neuron type of facial paralysis, which is the facial nerve itself or the nucleus, you have a complete half side of the face which is paralyzed. So this is the difference. In the lower motor neuron type of paralysis of the facial nerve, you have complete half side of the face paralyzed. In the upper motor neuron type of paralysis, you have the lower two-thirds of the contralateral side of the face is going to get paralyzed. So the facial nerve supplies the muscles of facial expression. It is arising from the facial nucleus. So there are facial muscles, stylohyoids, posterior belly of digastric, facial paralysis and loss of corneal reflex. It also supplies the muscle in the ear, which is the stapedius. If it gets paralyzed, then you have hyperacusis, you start to hear loud sound. It supplies the superior salivatory nucleus, which supplies pterygopalatine ganglion. So if it is lost, you have loss of lacrimation. It supplies the submandibular ganglion, which is supplying the submandibular and sublingual gland, which will result in dry mouth. And it supplies the taste sensations from the anterior two-thirds of the tongue. So loss of that will result in loss of ipsilateral taste sensation on the tongue. This is just giving a description of the same thing which we have just talked about. So we are coming to the glossopharyngeal nerve. We will finish up the glossopharyngeal and then we'll take a break of 5 minutes. So glossopharyngeal nerve is a mixed nerve which supplies motor, sensory, and parasympathetic supply. Motor to one muscle, which we said stylopharyngeus muscle in the pharynx. Sensory to general sensations to the posterior one-third of the tongue and pharynx, palatine tonsils, carotid sinus, and the body. And it regulates the gag reflex. When we touch the posterior part of your pharynx, there's a gag reflex. So the sensory component or the afferent component of the gag reflex is controlled by the glossopharyngeal nerve. It is special sensory to posterior one-third of the tongue. So taste sensation from the posterior one-third of the tongue is going to go through the glossopharyngeal nerve. Parasympathetic supply is through to the parotid gland through the aortic ganglion. So it is secretomotor to the parotid gland. And damage or disease will result in difficulty in swallowing and loss of gag reflex. So 9th, 10th, 11th nerve are usually tested by seeing the gag reflex. You just touch the posterior part of the pharynx. If any component of the gag reflex is damaged, 9th, 10th, or 11th cranial nerve, you would have loss of gag reflex. You can see the 9th cranial nerve coming out just behind the olives. So the groove between the pyramids and the olives is the place from where the 9th cranial nerve is coming out. You can see the different components of it. So you have the nucleus ambiguous, which supplies one muscle in the pharynx, which is the stylopharyngeus. You have the nucleus solitarius, which is shown in the orange, which takes the taste sensation from the posterior one-third of the tongue. Then you have the spinal trigeminal nucleus taking the sensations from the pharynx, from the posterior one-third of the tongue and palatine tonsils. And you have the blue, which is the inferior salivatory nucleus, which is supplying to the otic ganglion and then to the parotid gland. So blue is parasympathetic. Yellow, which you are seeing here, is the sensory sensations which are going to go to the general sensation, which is are going to go to the spinal trigeminal nucleus. Then the orange, which you are seeing, is the taste sensation from the posterior one-third of the tongue. And the red, which you are seeing, is the motor supply to one muscle, which is the stylopharyngeus muscle. So glossopharyngeal is important in elevating the pharynx during the swallowing. So it supplies the stylopharyngeus muscle. The problem with the damage to the motor nucleus will result in dysphagia. Salivation is through the inferior salivatory nucleus to the otic ganglion to the parotid gland. Usually it does not cause any clinical signs. Taste sensations, inferior ganglion, posterior one-third of the tongue, solitary nucleus, loss of taste in the tongue posteriorly, general sensations through superior inferior ganglion and posterior oral cavity, tonsillar region, auditory tube, middle ear, spinal trigeminal nucleus is the central part, anesthesia, loss of gag reflex, and chemoreceptors and baroreceptors to the inferior ganglion, to the solitary nucleus, and the loss of carotid and sinus reflex. So these are the some of the features or the supply of the glossopharyngeal nerve. So we will stop here and we will start with our discussion on the 10th, 11th, and 12th cranial nerve, and also some of the lesions of the brainstem, which we are going to discuss in the next hour of this presentation.